Okay, so Chris, I'd like to invite you to introduce yourself and take us through your presentation, if that's okay.
Brilliant. Thank you very much indeed. And thank you to Simon and Joe for inviting me to speak to you this evening. I'm going to share my slides with you now, which I hope you can see. So my name's Chris Carey. I'm an anaesthetist in Brighton. I'm also an Associate Postgraduate Dean in HEKSS, Royal College of Anaesthetists Council member, and I chair the Training Committee in Education, Training and Exams Board at the college. I was very closely involved with the development of our 2021 curriculum, and I'm Deputy Chair of the Curriculum Advisory Group. So I'm going to spend, I think, about half an hour or so. I'll try and get through in plenty of time to allow lots of questions at the end. So I'm very happy to take any questions that you may have, just talking to you a little bit about our new curriculum. So let's move through. So the areas I'm going to cover tonight are the rationale, why we've done this and why we've done it the way we have done, how the curriculum's organised and what that might mean for you, both the anaesthetists and the DMEs and people in charge of sort of managing rotations. The process for transition, which has been reasonably controversial, I think it's fair to say, but it's helpful to know exactly what the expectations are and how it will work. And also, I think we couldn't really have a talk at the moment without discussing a little bit around what the impact of the pandemic's been. And one of the first things that people ask me is, why on earth are you doing this at the moment? And there are some good reasons why we are continuing to move forward with transition during the pandemic. So I will just explain those to you as well at the end. So why is this important? Well, you will all know very well that a CCT curriculum sets out the template for consultant practice and values and behaviours. And really, more than any other document, it is a blueprint of what a consultant looks like, a senior doctor looks like, essentially. And so not only do we have a description of what the end product should be capable of doing, but we've also outlined the pathway to achieve this. And remembering, importantly, that most people come into anaesthetic training having had very limited experience through their undergraduate and foundation jobs. Some of them have done some, but on the whole, we have to set the bar, assuming that people have little or no experience of anaesthetic practice. So our current CCT curriculum is the 2010, or historical CCT curriculum has been used since 2010. Even that was quite a straightforward update of the 2007 curriculum, which only really changed the assessment methodology. In the intervening 11, 12 years since then, we have updated the curriculum with approval from the GMC, but those updates have been fairly minor things. I suppose the most major change was the introduction of units of training in perioperative medicine, which was about 5 years ago now. But there hasn't been a big change. And in fact, we waited 2 or 3 years knowing that there were some changes afoot from the GMC before embarking on designing the new curriculum, because we didn't want to get to a stage where we had to go most of the way to something and then start again. And of course, anaesthesia, unlike medical specialties, surgical specialties, is a single CCT. So we have to have a training program that supports flexibility, that will now allow us to introduce the idea or continue the idea of generalism in anaesthetic practice, but also enable us to train people in specialist interest areas as well. So what we've done probably represents the biggest structural change in anaesthetic training probably in a generation, since Kalman came in the late 90s to formalise the sort of registrar grade. So it is quite a big deal. It's been quite a turbulent few years, I would say, but we think that we've got something that we are now very proud of, and I hope you will feel the same. Just going back to the sort of whole idea that this has been pending since the last curriculum, which was essentially being thought about the same time as these came in. This is an original iPhone. And this just takes you back to 2007, those happy halcyon days of 2007, and remembering what the world was like. It was a very, very different place. And technology was different, medical education was different, the way that we approach clinical practice was different as well. So it just gives you an idea of how things have evolved over the last 15 years. Now, the drivers for change, obviously the main driver for change came from the GMC with their generic professional capabilities framework. And this includes the 9 domains, which basically encompass knowledge, skills, and behavior. And I'm sure that many or all of you will be familiar with these 9 domains. And the GMC's requirement is that these 9 domains must be incorporated within all specialty curricula and really embedded at all stages of training. Now, I have to say that we paid some service to all of these areas in the old curriculum, but I couldn't put my hand on my heart and tell you that it was well embedded in a terribly joined up process. People had to say that they'd done a little bit of all of them, but there was very little in terms of standard setting and assessment in particular. And that's something that obviously we've changed in line with all of the other medical specialties producing their new curricula. So what else was a driver? Well, again, I'm sure that you will remember, and this is going back quite a long time now, Shape of Training Review, which came out in 2013, and we rather thought that it had been parked in the long grass, I think the saying is. But in fact, when we first approached the GMC, when we were first having conversations, we were very much expected to follow the principles of the Shape of Training report. So meeting challenges of trends in patient and population, in particular for us, I think the aging population is something that we're going to need to take really, really seriously going forward. And the complexity and the multiple comorbidities of perioperative patients is something that I think is becoming a much more emphasized part of anaesthetic practice. We need to maintain general skills for managing unselected emergency work. And we're very proud that we've always trained people to be able to take on generalist practice at consultant level, supporting trusts, hospitals with an emergency department where anything could come through the door, children with head injuries, critically ill children, patients of all ages, with all sorts of things. And the rationalization of things like trauma services have changed the landscape to a degree, but I think we still would very definitely say that where there's an emergency department, you could be called upon for anything. And as the on-call anaesthetic consultant, you may be called to some really tricky things that everybody else needs support with. So it's not a straightforward proposition. We were given a bit of a pass on this one because the support from community-based care isn't quite so relevant to anaesthetic practice, although with perioperative medicine, we are trying to reach out and have a much more holistic and much more team-based approach, which certainly includes people in primary care. So we are working towards that more than we perhaps were in the past. Flexibility, I've already spoken about the fact that we must be able to train generalists and specialists, and we had to adapt to principles that would enable us to do that flexibly, and also allow for workforce requirements as well, which may change from one flavour of an anaesthetist to another over time. And then looking at areas that may form credentials, and this is something actually that's really taken off. And one of the very first credentials that the GMC is considering is actually pain medicine, which has always been part of anaesthetic training, and we're really pleased about that. We're also looking at a credential potential in perioperative medicine in the future, so I think we definitely have embraced that idea. The other thing that was really important to us and very timely was this report of around 2,300 anaesthetists in training, which was published at the end of 2017, which was a report on morale and welfare, basically, and came back with some really challenging findings for us. Remember, this was in what were, in hindsight, relatively straightforward and uncomplicated times, but there was a lot of unhappiness about many elements associated with the training program. So we were able to look at this and act specifically on things like duration of placement, where very short placements that were perhaps replicated in specialist areas, we tried to amalgamate into single longer placements. Timing of exams, in particular the primary FRCA, was very problematic, and also the assessment burden, which was found to be a high burden, but perhaps not as helpful to formative progress as it could be. We also wanted to look at addressing some of the inconsistencies in anaesthetic training, and it was very clear that across the UK, there were some major differences in how higher and advanced training, so this is really ST 5, 6 and 7, was being delivered in different parts of the country. And we really did feel that if we are trying to produce people with the same CCT who can be applying for the same consultant jobs, we needed to act on that and try and make things a little bit more consistent. And then the workplace-based assessment and exam strategy we wanted to review as well. And then the final thing, which really came from the GMC, but actually something we already knew about, was what, as I was alluding to earlier, with the workforce requirements in anaesthesia. There is a significant shortage of consultant anaesthetists. Census data undertaken by the College of Clinical Directors suggests that we are probably 600-700 consultants short of an overall consultant workforce of just over 7,000. So getting on for a 10% shortfall at a consultant level, and the numbers are quite large. And we needed to introduce sort of flexibility to try and improve through the training program, and also to look at which particular areas were being affected most adversely with the shortage at consultant level. So the changes that we have embedded in the training program are really to have anaesthetic training organised into 3 stages rather than the old 4 stages, core, intermediate, higher and advanced. And the biggest change, I think the single biggest change, is this 3-year core anaesthetic training that's going to be termed stage 1, that is being termed stage 1, I should say now. So this is obviously a year longer than the historical 2-year core anaesthetic training program. So sorry for the jargon, people that aren't anaesthetists, but this 3-year program includes the initial assessment of competence that enables people to then participate on core rotas and undertake clinical practice without direct supervision. So there's an importance both in terms of training progression, but equally in terms of the logistics of running a department, that people traditionally take about 3 assessment before they can participate in any sort of on-call service, which can be quite a challenge for smaller departments with several people coming through the novice programs. There's also an initial assessment of competence of obstetric anaesthesia, which is very much the same principles, and importantly, the primary FRCA exam in that 3 years. Within the stage 1 program, there will be 6 months spent in intensive care medicine. Again, at the moment, only 3 months for the 2-year core training program. And we really felt that intensive care medicine is such a complex and difficult environment to start out in, that it would be nice to enable people to have a 6-month block, if that works for schools, rather than just going 3 months and never really feeling embedded in that part of clinical practice. A period of time spent in obstetrics, we suggest 3 months, and then into that introduction to paediatric anaesthetic practice, although the expectation is pretty low in terms of what we would expect people to do unsupervised for children. So for those of you that are familiar with what the training program used to look like, it looks really similar to the old core training 2-year program, plus the general half of intermediate training as it was. So stage 2, which is uncoupled, so competitive entry to ST4 now rather than ST3. Stage 2 is 2 years of ST4 and 5, with a final FRCA at the end of ST5 and a single attachment required in a specialist centre for neurocardiac orthopedics to try and prevent these multiple short attachments and lots of movement around. And then the stage 3 in the new curriculum is 2 years, ST6 and 7, of which 12 months is spent gaining the skills to be a generalist and participate in a general on-call rota. And then there is a year spent undertaking training in special interest areas, which I will give you some more information about in just a second. The way that the curriculum is organised has fundamentally changed as well. So previously we had a very modular training programme where the anaesthetic side of it was really related to which surgeon you happen to be sharing your operating theatre with. And it wasn't really focused on anaesthetic practice or the patients in particular. We wanted to go away and embark on something that reflected the clinical care that we give to people first and foremost, as opposed to what operation they're having. We have divided basically each stage into 14 domains termed high-level learning outcomes, of which 7 are professional and 7 are clinical. So the first 7 are professional, so behaviours and communications, management, teamwork, and safety and QI, safeguarding, education and training, and research and managing data. Those numbers in the middle column refer to the generic professional capability, the GMC, GPC that these align to. And then we've got a high-level descriptor. The clinical high-level learning outcomes, again, perioperative medicine, general anaesthesia, regional anaesthesia, resuscitation transfer, sedation, pain, and critical care. All of this is within the old curriculum, but the way that we've organised it is very different indeed. And it will take a change in mindset around how clinical training is delivered and how assessments are carried out as well to support the changes. The descriptors basically set out the capabilities that are required at each level for each of those 14 domains, the 3 stages, and how they may be demonstrated. Now, it's an example of how they may be demonstrated as well. They describe progression, so they start out simple and get more complicated through the training program, which is not actually something that particularly necessarily applied in the old curriculum. There wasn't this sort of obvious stepwise in terms of the educational challenge of the training program escalating throughout. They map to pretty much everything that we do at the moment. Historically, there's been a huge list of individual competencies that people must demonstrate capability in, essentially, or competence in, I suppose I would say. And that stretches to several hundred pages. So there's an awful lot of detail. We do not go into anywhere near as much detail with this new curriculum, but we do expect people to be doing the same things to essentially the same standards, but the way it's assessed and demonstrated is a little bit more holistic rather than just the tick box mentality of ticking off a particular skill or a particular competence, which we knew people didn't like. Although interestingly, I've already had some feedback from somebody who was half joking when he said that actually that enormously detailed list could be seen as a comfort blanket to people who knew exactly what they had to do in much more detail than they do now. But I think we can certainly support people to move beyond that. Some of those 14 domains are fairly brief. So sedation and transfer, for instance, of the clinical side. Others are much more lengthy. So general anaesthesia, of course, which encompasses the vast majority of clinical practice for most anaesthetists. And the challenge that we faced is to provide the appropriate level of detail so that we can set a marker for what people need to do without giving them far too much detail and making things inflexible. And we've also introduced something you may have heard of fairly recently, just in the last few months, which is educational development time. And we've got some guidance for schools, which we hope is being implemented in trusts throughout the UK, at allocating time for undertaking activity which supports those professional domains. So formal time for preparation of education material, quality improvement work, other things that fall into those 7 domains. And this is something that's already embedded in the foundation programme. And I think our Royal College of Emergency Medicine have also done something similar with their training programme too. So we do suggest that there is specific time for those GPCs to be completed. Special interest areas, so many anaesthetists are generalists, but most of those generalists also have areas of practice that they would particularly identify within a department. And then there are some that specialise in more niche areas and dedicate more of their clinical time to particular areas. So the I suppose, what I would call the big ticket specialist areas that people would need to demonstrate very specific skills in for consultant practice are neuro, cardiac, pediatric, obstetric, perioperative medicine, chronic pain and intensive care medicine. We do allow an additional 6 months for people working in smaller units who may wish to support critical care services where those units don't feel able to recruit a large number of ITU, CCT trained consultants to manage their unit. We wouldn't expect somebody with that 6 months to provide leadership in a critical care scenario, but they could certainly participate in on-call services, for instance. And then the other areas, and I'm hoping that you can see this, unfortunately the screens are blocking some of them for me, but I hope that's not the case for everybody else, are acute pain, regional bariatric hepatobiliary, military anaesthesia, orthopedics, plastics and burns, and then some more that I should be able to remember off the top of my head, but I can't read, so I'm not going to mess with my screen trying to change it, but hopefully you can see all of those. These are areas that support generalist practice in general departments, and it is of value to those departments to have additional expertise within their consultant body and additional leadership within their consultant body without people dedicating all of their clinical time to these areas. So that's the idea, to support people undertaking those roles. And these would be expected to have between 3 and 6 months in stage 3. So I'm going to talk about CT3 because this is the thing that's slightly controversial. In moving our HST recruitment from ST3 to ST4, we have created a gap for people which we are going to have to work through over probably a fair few years, and it has caused a lot of challenges. However, I think the case for change is very compelling. Now, I want to show you this. This slide is taken from the GMC ARCP outcome data that's on there. It's actually on their NTS reporting tool, and you can look at outcome data as well for different specialties. And this gives you a view of unsuccessful outcomes in core anaesthetic training over the last 10 years or so. And you will see that the average over that 10 years is just over 20% for a 2-year training program. Now, actually, what that 22 or so percent in fact represents is around 40% of CT2s getting unsuccessful outcomes. It's very hard for a CT1 not to receive a successful outcome in their ARCP because there isn't, apart from IAC, there isn't really very much that people need to have completed by the end of CT1. It's a 2-year program. So the unsuccessful ARCPs are almost always, with a very few notable exceptions, awarded at the end of the 2nd year. So taking the entire cohort of core trainees, actually, if you look at CT2s, it's nearer 40%. And that's been something that's been steadily getting marginally better, but of course it's suddenly got a lot worse again, but remains a big problem, and a problem over a number of years. And remember, we started looking at this in 2017, so we were really looking at the data from 2016 and beyond when we were thinking about the curriculum plan. And we felt that that was really not appropriate, that we know that our core trainees are high performing, they tend to do well in other academic areas historically. It's interesting that they tend to perform very highly in other exams, actually, apart from the FRCA, which is the majority of the reasons for not progressing through the core training program. So given that it's such a large proportion of what we consider to be a very dynamic and talented group of people, we arrived at the obvious conclusion that it was important for the training program, and that we needed to do something about that. We reckon that more than 3,000 trainees have failed a year of anaesthetic training, at least 1 year of anaesthetic training in the past decade. And that really is something that we felt was completely unacceptable and represented a problem for the training program. Just by way of comparison, this looks at that average over 10 years and compares anaesthetics to core medical training which of course had the same problem and was also moved to a 3-year core program, partly as a result of that. Core surgical training, much better. Everybody has this idea that core surgical training had a very high failure rate, but their failure rate was actually probably a third less than ours. And if you compare with general practice, for instance, the rate is much lower for general practice, somewhere around 8%. So we really were, I think, failing our trainings with the old way the training program was organised. So looking at the benefits that we think, that 40% that can't finish their entire exam by the end of CT2 will now have a year longer. And in fact, something that's an anaesthetic fact is that there was also a cohort that sat the exam in May and may have passed and finished their CT2 year with an outcome 6, but they still wouldn't have been able to get a job because you have to have completed the exam by February to get a job. So there was even greater number actually of people who couldn't progress. In terms of clinical experience, the 3-year program will allow more exposure to obstetric anaesthesia, that great consolidation of experience in intensive care medicine, and general experience of more challenging cases, which we think is really helpful for people who are moving into registrar posts. And then there is an efficiency advantage for the system as well. We know we're short of consultants. Historically, the average time in a training program, excluding things like maternity leave, has been nearly 9 years. And actually what we need is to get people through a 7-year training program in 7 years and not 9 years. Just for those who have a passing or significant interest in ACCS, the ACCS curriculum has also changed, and it will continue to have that additional year of acute medicine and emergency medicine within it. So we think the advantages are that we have increased the clarity of the learning outcomes for each stage of the curriculum. We've got additional time for trainees to undertake exams. We've got a consolidation of experience, which now allows people to gain more experience and better sort of understanding of anaesthetic practice before they have to apply for HST posts. There are far fewer units of training required, which we hope will definitely mean that trainees don't have to move around nearly as much, and will also give training program directors a lot more flexibility about how they run their rotations, and a hopefully more pragmatic use of assessments. I haven't spoken to you in detail about assessments tonight, just because I don't think we've got time, but we have a new and updated assessment methodology, which I suppose the headline is doesn't include the use of multi-trainer reports, which I know has come in a lot of other specialties under various different names, but we feel that that offers a really good opportunity for a much more holistic way of assessing trainees. And then we honestly do feel that this is going to give us a much more consistent approach to training towards the end of the CCT program, and allow us to plan our anaesthetic workforce with a bit more precision rather than just a sort of random whoever comes out. There will be a job for them, but there's not a planned approach to that at the moment or historically. So the transition is taking place from August last year or February for people that rotate in February, and we expect it to last for 2 years or so. We put out some guidance for schools about where we suggest people go to and where we suggest they transition, although there is some flexibility, especially around ST3, 4 and 5, about how they complete anything that might be remaining in the old curriculum and move on to the new one. There will be a lot of flexibility when we in our sort of dealing with schools and approving programs in the first 2 years. And I think we've spoken to a number of schools and allowed them to sort of bend things around a little bit to fit in with historical patterns. And we'll continue to do that certainly for a couple of years, I would say. However, everything must be completed. Now that's incorrect actually, by February 2024. So it's not February 23, it's February 24. So we've got 2 more years, and then everybody has to be on the new curriculum. So that in itself will present a challenge for people such as less than full-time trainees, people undertaking significant time out of training for research, for instance, and 1 or 2 other examples. But we really have set that deadline by which everybody must be on the 2021 curriculum. So we have some information as guidance for schools about how they can recognise the learning that people have achieved on the old curriculum and use that in a sort of matrix to sign off stages 1 and 2. And we will obviously continue to support people on an individual basis where questions arise around that. I think that's really important that we undertake to do that. So this gap between CT2 and ST4, there were several hundred people last summer who weren't able to obtain an ST3 post. There was quite a lot of unhappiness, and we absolutely recognise the concern and the stress and unhappiness that this has caused for trainees in particular. We introduced CT3 top-up posts so that everybody that's finished a old style CT2 year and exited will then be able to make up the other year of training to complete stage 1. And this is in a similar manner to what the RCP are doing with their IMT top-up posts, but we didn't organise specific identified posts for it because we wanted a little bit more flexibility about what people did. And I think in hindsight, that was the right decision because actually people haven't done exactly what we expected them to do. So if we'd set up lots of posts with this in mind, I think that a lot of people would have done something else anyway and they could be sitting empty. There's a gap analysis that we've got on our website to support people identifying the areas they need to complete for stage 1 sign-off. And we're surveying them as well. We've got some survey results in looking at some really important things about terms and conditions, pay, access to educational supervision and study leave, things like this, because this will essentially count as a year of people's training. So the ask was that they were treated with the same courtesies as trainees would get in terms of educational supervision, access to training lists, study leave, budget, and pay as well, which is a very important element. But this has much wider implications because CT3 top-up posts will only be around for a couple of years. Once we've got this cohort of people signed off at stage 1, we won't need to do them in the future because everybody will be on a 3-year core training program. But I think what we would all recognise is that the boundaries of training and non-training in terms of progression to the point of CCT are becoming more and more blurred and will continue to do so. And what we're really interested in is the principles here of how people who want to train towards the point of CCT but aren't necessarily in a recognised training programme, how they will be treated and how they will have their sort of terms and conditions recognised by employers. So I think there'll be some really important learning for this, and the BMA have been involved in this study as well. The next round of HST recruitment, of course, is not going to be August this year. We're going to have a pause, but there will be ST4 recruitment from next February. We think with some additional posts as well as part of the expansion of training posts, this 3-year expansion program that HEE are embarking on. And we hope that the devolved nations will be looking at their programs as well. And then we've also released, or are about to release, I should say, a document outlining how we can recognise training completed outside of the training program more flexibly in the future and potentially allow people to have time recognised towards their CCT program and signed off by schools, basically, as part of their sort of enhanced ARCT process. So I hope that will be out in the next sort of month or so. Finally, very quickly, the impact of COVID. Obviously, we know that there's been a lot of all sorts of educational opportunities, not unique to anaesthetic training, but I think anaesthetists have felt it very keenly given their sort of involvement in clinical services to support the pandemic. There is a system of derogation, obviously, in place across all specialties. And we moved the requirements for completing the whole of the primary FRCA to the end of ST3. So people only needed the MCQ to apply for those last rounds of ST3 posts. So this has essentially moved the milestones, the academic milestones that were historically at CT2 and ST4 back a year, which in fact really dovetails very neatly into what stages 1 and 2 of the new curriculum will require. So in fact, we didn't want to go back to the old way of doing things and suddenly requiring everyone to pass their exams at the end of CT2 and ST4 again, because we realized that that would be very difficult to achieve for numerous reasons. But we do feel that moving from the current process of derogation into a new training program based on a curriculum with milestones that are a year later in the program, we will be able to smooth the passage of people who have had requirement to delay their training so far. So in summary, there are some very significant changes to the organisation and delivery of anaesthetic training. And it's important to recognise that there are internal factors such as our morale survey and external factors from the GMC shape of training. They have allowed us, though, to also look at some of the concerns and inconsistencies that we'd identified historically. Transition is going to be challenging, and we may want to talk about that a bit more in the Q&A if you'd like to. I'm very happy to talk a bit more about the transition process, but we do hope that we will get to a stage where everybody can enjoy the benefits of the new curriculum. And we also hope that that will support people being able to progress as we hopefully try and come out of the disruption caused by the COVID-19 pandemic. So thank you very much indeed. I'm going to stop there and I'm going to stop sharing my screen. So I'm very happy to take any questions that you might have.
Chris, thank you very much for a very comprehensive piece of work and presentation. I'll open it up for questions. We've got up to the next 20 minutes. Anybody wants to raise their hand, put their camera on? Gillian, do you want to go first?
Thank you. I've got a slight problem with the camera, so apologies for that. Thank you, Chris. Clear, concise, and very informative. Thank you. In emergency medicine, there's a very large group of middle grade doctors who are applying for CSER as opposed for CCT. I just wondered at Royal College of Anaesthetic sort of council level, whether there would be any development in accessibility of anaesthetic training posts for those kind of groups, very large groups of doctors. Here at Northwick Park, we have a very large group. Our CSER program works well, but the weakest link is the ability to get them to have anaesthetic experience. Chris, anything that would help me?
So I'll take, thank you, Gillian, and thank you for your kind comments as well. I'll take those two questions slightly separately. So we are definitely looking at how the college can support parallel CSER training programs or parallel training programs. And there are several that have sprung up across the country. I know that there are 2 or 3 in London. Big centres like Annenbrooks as well are looking at doing things. Historically, we were not particularly forthcoming because actually until 2018, we didn't fill ST3 posts every year. We had 90 to 95% fill rate at ST3. So we didn't feel that putting extra programs in would be the answer when we already don't fill the programs that we have. However, that's all completely changed now. And we do feel that there is absolutely a place for parallel programs for anaesthetic training. And we're looking at how we can work with people managing those programs to support them. And that will include supporting them through our regional advisory college shooting network, for instance. In terms of how we can get additional emergency medicine trainees through programs that require anaesthetic experience, this is a very long-standing problem, which I'm sure you will recognise, and a challenging one. As I explained, there is effectively a 3-month supernumerary training period to get people initially up to speed with anaesthetic practice, 3 months or thereabouts. I think it's easier if they're coming in seconded from another post, because obviously then there isn't the financial pressure on the department. And I think it's much easier if people come in at other times of the year than August, and perhaps at other times of the year than February. So November and May would be the most obvious times, because that's the times of year when most anaesthetic departments don't have any novice trainees of their own. But it does really sort of come down to developing good local relationships, because I do think that they need to stay within the same organisation. It's a very challenging thing to embark on, and I think they need the support and the educational supervision support, for instance, that staying in the same trust will provide for those trainees. So I think it comes down to having a really good understanding with your own anaesthetic department, who I know are fantastic and a great bunch of people. So I think if you go to them and talk to them, they would be bending over backwards to support you, because we recognise we absolutely need to train more people in emergency medicine. We completely get that. So we need to help.
Thank you, Chris.
Lovely. Thank you, Chris.
Thank you, Gillian. Anybody else would like to ask questions? Ahmed. Oh, I can't hear your audio, Ahmed. You're unmuted, but we can't hear you. Apologies. Ahmed, do you want to put your question in the chat? For some reason, your audio is not picking up. And is it Sujatha? I'm sorry.
Yeah, that's right, Sujatha. Hi, I have just one question. Like some of our trainees who were unsuccessful in getting into the ST3 post have joined the Imperial Clinical Fellow Caesar rotation. So will this be incorporated in the formal training?
So that rotation, I think, will continue to be seen as a sort of parallel training program. The complexity of incorporating it into a formal training program is really more around the funding and organisation of schools of anaesthesia and the responsibilities of the SEBs who manage schools and training programs through schools, and the way that they are funded and the way that they have planned their sort of UK-wide workforce, and the standalone programs such as one you mentioned in Imperial really are standing alongside that. And actually, I do think there is a lot of positives to being slightly separate from the big part of the system. I'm not saying that the way schools of anaesthesia work isn't a very good thing, because it is. But actually, I think firstly, it's very unlikely that they're just going to take in Imperial, for instance, another 10, 15, 20 people from your program and incorporate them into the school. And there would be some real downsides, I think, for the school for doing that, because it may lead to problems in the future with them getting posts redistributed back across the UK. But equally, I think you can use some of the expertise that you have in terms of the trainers, educational supervisors, that of course is managed by HE and will continue to be, because they look after the training environment. So that obviously I think you can utilize the sort of benefits of that, but probably it will remain separate. However, there is one thing I would say to anybody sort of thinking of doing this, and that is the lifelong learning platform is really, for me, the cornerstone of demonstrating progress through training. And I would urge anybody that's thinking about doing this to make sure that whoever they employ is utilising the LLP fully, to make sure that they're recording their training and their assessment and their progress, because then it will be a very, very straightforward matter of going to a CSER CP route and getting on the specialist register. I'm not even sure if it will still be called CSER. I think it's all going to be called CCT actually in the end, ultimately. But that pathway to the specialist register will be much easier for people that can demonstrate evidence in the LLP.
Thank you.
Thank you. Chris, Ahmed's put his question in the chat, and what he said is, how do you feel about the number of cases and case mix in the trainees' logbooks of those approaching CCT because of the impact of COVID?
Yes.
So
that's a really thorny question, isn't it? It's a really thorny question. I think it's concerning. I think the disruption to training has been very concerning. I suppose I would say that there's a lot of learning that has come out of it, but it's probably slightly different learning, and not what we had initially planned people to learn as part of their training program. But I do think people will have gained an awful lot of skills that perhaps it's frustrating for them that they're not formally recognised towards their training. So that's one thing. And in terms of working collaboratively and flexibility and resourcefulness and resilience, I think everybody has done such a magnificent job, and there has been no end of achievement in those areas. In terms of the specific case numbers, I think there are some areas of training where this is potentially going to be more of a problem than others. I think there's a bit of flexibility around those things, but some areas like cardiac, anesthesia, neuroanesthesia, not so much actually. I'm a neuroanesthetist, and we haven't noticed a big fall off in numbers, but cardiac services have been hit particularly hard. And if you're not doing any elective cardiac surgery, it's very, very difficult to undertake advanced training. Pain medicine as well is another one that's been hit really hard. And actually it's improved in the last perhaps 6 to 12 months, but certainly for the first year or so, pain medicine was really something that was disarray is not the correct term, because that implies that it was badly organised, but it was really severely impacted. So I think there will be areas where people may need to spend some additional time. We've tried to be very flexible. We've actually said that we're prepared to allow people as part of that derogation to only do 8 months of advanced training towards a CCT program rather than the historical 12 months. And I think we recognised that there were people that were coming to the end of their training that already, in some cases, had jobs to go to, who were going to really struggle to achieve an outcome 6. And we wanted to try and make sure that the people that wanted to get through and the people that had done the training they needed for the jobs that they were going to be doing were able to do that. But I think there may be some people that would like to spend a bit more time, and we've left the door open for that as well.
Thank you, Chris. I've got a question from Mohammed, and I think if I understand this question correctly, it relates to clinical fellows applying who've done training and gained the competencies who are applying for entry into ST4. How does that work? And will it be possible to gain CLTC? I don't understand that one.
Yes. So the answer is yes. So we've historically always had an equivalence recognition for core training, which enables people to apply for HST posts who haven't been through a recognised core training program, and that's always been something that we've offered people, and we'll continue to do so. So it will be slightly more comprehensive in terms of the experience they'll have to demonstrate, but there is a process for achieving a stage 1 sign-off having not been in a core training program. And if people have got questions about that, there is some information on the website. It's probably not something that I should go into now because it's quite technical and complicated. There's information on the website, or college tutors, training program directors should be able, and regional advisors in anaesthesia should be able to give you a little bit more information about that. But I would definitely say the website's the first port of call for that.
Thank you, Chris. I'm going to just leave you with this last question here. Carl's had to go, but he was going to watch the recording for the full answer. And I might get you just to read it in the chat, get people reading the chat, because it's quite a long number of questions and comments, if you can see that.
Okay.
There's an observation and there's 3 questions.
Right, hang on, I'm just struggling with my chat, hang on. One observation and 3 questions. We've noticed that the EPA format of the IAC has made it harder to sign off ED trainees, as beforehand they could pass assessments without being expected to be able to go, in theory, go on call for the anaesthetic department. Any concern that the problem of exam, so question 1, any concern that the problem of exam failure will be displaced to ST5 in the final? I think most people that historically failed exams did pass them within 12 months. So we fully expect that the vast majority of people who were struggling with exams and getting unsuccessful outcomes, getting outcome 3s, will have that extra year and will be able to progress at the end of that extra year. I do recognize that there will be a much smaller number of people that will still not have passed the exams by the end of that longer program, and they will still have to be given outcome 3, but we hope it will only be a fraction of the historical numbers. But I think, yes, the answer is you won't progress past ST5 until you pass the final FRCA. There may be flexible ways around that, but the rationale for that, I think, is that the FRCA exam, the anaesthetist on call will know it's incredibly challenging. It takes up your entire life for 6 months. And it's very difficult to be fully engaged with advanced training and the challenges of really the final stages of the training program and preparation for consultant practice while your mind is still focused on the exam. And that's why we've been quite keen to hold the line that we don't want people to start those final 2 years of training until they've got the exam, just to allow them to really fully focus on that learning. And I think that is the right thing. Question 2 is, how does FEM fit into 4-year ST program previously across ST5 and 6? So question 2, so FEM are developing pre-hospital emergency medicine, sorry, I should say, FEM are developing a new curriculum themselves. Actually, their curriculum maps to the special interest, some of the special interest areas that we've already put into ours. So we think it will be seamless for people to undertake the training in pre-hospital emergency medicine as part of their special interest training, which may be at either ST6 or ST7. So we don't anticipate that will be a problem. And we've seen the new FEM curriculum, and it's got approval from the Royal College of Anaesthetists Council. So we're happy that we'll be able to support that. And then finally, question 3. For EG management of critically ill child, transferring stage 3 of management of patients with complex cardiac disease and non-cardiac surgery, assuming that if trainees don't actually encounter these in the last 2 years, should we provide simulation training and assessment? Absolutely. I think both of those. I think you probably will encounter people with cardiac disease in reality. It's interesting, it's probably not as many people with severe, uncontrolled cardiac disease as there was 10, 15 years ago, which speaks volumes about the effectiveness of cardiology, really. But there are still a lot of people with significant comorbidities having surgery more than ever, in fact. So I wouldn't have thought that would be a problem. The pediatrics thing very much might be, because this is not something that happens commonly, but anaesthetists do have to be able to manage it. I absolutely think that there is a role for simulation in that. I think there's a really important role for simulation. And in fact, I think there are increasingly important roles for simulation at several stages of the curriculum and several particular areas that really massively benefit from the use of simulation. And it's certainly something that we've put in our assessment guidance, is that there are several of the technical procedures, for instance, that can be assessed and demonstrated as part of a simulated practice rather than in real life.
Chris, thank you. Thank you. And there's a few more questions coming through. I'm going to just take one final one and then call it an evening, because I'm conscious of trying to keep to time. So the very last question is, from Mohammed, which I think relates to, is it advisable to sign CT3 top-up year on the LLP, which I think is at the Lifelong platform?
Lifelong learning platform, that's
On
right.
the 2010 platform, or move to the 2021 platform? That should be...
So the CT3 top-up year, I would suggest people try and complete the requirements for that on the 2021 platform for the LLP. It's a source of frustration that the way it's set up doesn't allow people to run two portfolios side by side. So you can't have a current 2010 portfolio and a current 2021 portfolio. It's got to be either or, but my advice to people would be to move to 2021.
Chris, thank you very much. I'd like to thank Chris and everybody for joining us this evening on one of our NAT webinars. We continue to run them every few months on different themes. I'd be really grateful if you'd be kind enough to give us some feedback. There's a short SurveyMonkey evaluation there. We will record this. Well, sorry, it has been recorded and it will be on YouTube. So if you think this is really helpful for other people to have a look at, you couldn't make it tonight, or you want to recap anything, please have a look in the NAT website. And if Chris has given permissions, will you happy to share the slides on there?
Oh, absolutely. Yeah, I'll send you a copy of my slides and you can use them in whatever way you see fit.
People want to sort of share them in other departments. So thank you very much, Chris. It's been really thoroughly entertaining. I think we could have kept you here for another hour with questions, but I'm going to let you off because I know you've had a busy day. So thank you.
If you would like to email questions to me, I'm really happy for people to do that as well. So if there are other things that you want to ask about, please do get in touch.
Brilliant. Okay, so the SurveyMonkey's in the chat if you can feedback. But otherwise, I'd like to say good night and a pleasure meeting you. And I hope to see you on some future of our webinars. Take care.
Thank you, everyone. Thanks for coming to listen.
Thank you.
Bye-bye.